Good afternoon, and thank you everyone for attending today's webinar, Physician Practice Checkup, Revenue Cycle Optimization and Related Compliance Challenges, Trends, and Best Practices, brought to you by Catherine Ruggieri and Mark Stein of Withum Smith & Brown. Please be aware that there will be a question and answer portion today at the end of the webinar. To avoid frequent interruptions during the webinar, please type your questions in the question box located on the right of your screen. They will be answered in the order received during the question and answer portion. Additionally, an electronic version of this presentation will be emailed to all participants following completion of today's webinar, and a recorded version will be available on the website for members only. Again, we would like to thank you for attending, and I will now turn things over to Catherine and Mark.
Good afternoon, everyone. Thank you for joining us. Our abstract for today's session, we will be discussing implementation of revenue cycle improvements, use of a dashboard, and a compliance risk assessment and plan are critical for financial survival in today's physician practice environment. With declining reimbursement, many practices are seeing their profitability decline. Per MGMA stats, most practices leave up to 30% of potential revenue on the table every year, and this really can be the difference between staying open and independent. The issues surrounding revenue leakage are all known. However, due to resource issues and lack of sophistication and existing processes, some practices just can't fully get their arms around some of these issues. So today, as our goal, we will be discussing the revenue cycle continuum. We'll explore some leakage areas and some best practices associated with those. We will also discuss the value of the use of a dashboard and the benefit of a compliance plan and a risk assessment. And as I mentioned, we'll also open up to questions at the end. And during the course, we'll have a couple polling questions as well. So just as an overview, what is the revenue cycle? I think, we all know what they are, but we'll just do a quick run through. It's really all administrative and clinical functions contributing to the capturing and managing and collecting of patient service revenue. So really simply, it's really the entire life of patient account from creation to payment, or unfortunately, in some cases, non-payment. Some accounts never do get paid. So it's the entire life of your patient account. A healthy revenue cycle should follow billing and collection best practices to ensure that the bills are submitted in accordance with your payer requirements, and of course that all services provided are billed. The last thing we ever want is to provide services and care to our patients and not be paid for the care that we're providing. But the revenue cycle continuum is complex and it's involved, and there's many components, and unfortunately, because there are so many components, it can lead to potential disconnects. Many of the areas within the continuum rely on one another to actually work optimally and to perform optimally. The revenue cycle continuum begins, as we all know, with scheduling of our patients. Ideally, you want to obtain good financial and demographic information in advance of service and speak to your patients in advance after looking at their eligibility and so forth, so we can notify them of what's expected financially. In terms of registration, it's really the office staff's interaction, that first interaction with the patient when they arrive, really strong, effective check-in procedures to include the collection of the patient responsibility amounts and any past due balances. Our charge capture and coding and documentation areas is really, this is where the revenue occurs. We want we have the clinical documentation for it to be optimal and cover everything that happens with the patient on the visit, and then the bill to actually reflect that as well. So it would be a consistent and accurate picture of the medical record. Electronic billing, for the most part, most claims are billed electronically at this point, and having a really strong reconciliation process with the claims that are going electronically to ensure that everything is getting through the clearinghouse and having the controls and dashboards, which we'll get to a little bit later. Managed care contracting, another critical piece, sometimes can be very challenging on the physician practice side. A lot of times there are evergreen agreements that just roll over from year to year, and there's no changes with contracted amounts, and we'll talk about that a little bit further as well. Denial management, you know, there's a plethora of reasons for denials, and really understanding what the denials are and how to really get to root cause correction is also a component of the revenue cycle continuum. Payment posting is pretty simple at this point in terms of most of that is automated. And then moving into AR follow-up, making sure that working the accounts that are not paid timely, and that kind of goes hand in hand with denials management as well, and really making sure that the unpaid accounts that are aging within your receivables are being paid. And then patient collections, you know, a lot of that really is essentially done upfront at this point, but the self-pay portion, you know, with the patients in terms of their responsibility. And then kind of bring it like kind of full circle, you know, using reporting and benchmarking tools to really be able to kind of look 20,000 feet, you know, at our practices and making sure that we're identifying the trends and the problems and using those tools to be able to make the corrective action that's needed. So that's really the continuum in a nutshell. So where can things go wrong? Where are some of the most common leakage points? You know, we're going to be talking today about patient responsibility portions that are not collected, insurance eligibility issues. You know, patients are coming in, they're providing cards, but then their services are not paid. Coding errors and omissions, disconnects in that area, lack of follow-up, and then underpayments as well. So we're going to move forward to a polling question.
Okay, so here's our first polling question. How many Americans still have a bill in collections? 10 million, 24 million, 43 million, or 65 million? Give everyone a few more seconds. All right, I'm going to close it out. And here are the results.
Okay, so the correct answer was C, 43 million. So 52% of the group got that one, 89% voted. So thank you. So we're going to talk a little bit about, you know, what causes that. And a lot of it is really the collection of, you know, the collection of the patient responsibility amounts. Hold on a second, we're just going to advance the, okay, there we go. Sorry, little technical problem. Okay, so, so statistically, approximately 25% of the bill is due from the patient. And as we know, the high deductible health plans have had such a huge impact with regards to this. Three out of four employers now offer a high deductible plan. So what does that mean? That means so much more responsibility on the patient. And that is just something that, you know, 10 plus years ago was not a hurdle and obstacle for us. So it really understanding what's due from the patient is critical. And bottom line, insurance payments alone will unlikely cover the cost of the services provided. So we're really looking to the patient that they will be responsible for something. Practices, generally, from a statistical perspective, collect about 50% of what is owed from the patients up front at the time of service. The first line of defense in preventing patient responsibility leakage is, as we know, is the front desk, registration desk, and your scheduling staff. So really having those discussions prior to service so that we can be educating the patients in terms of the their responsibility and there are no surprises. Patient responsibility is not collected due to the following. Sometimes the front-end staff don't have the understanding or the skills to collect the patient responsibility up front. Sometimes staff are reluctant to ask for money and will just repopulate forms and information in the system from a prior visit. And some practices lack tools and automation. So from a best practice perspective, I think, integrating the insurance eligibility into your EHR practice management system is really a best practice at this point. So really knowing when you're running, you obtain the information from the patients, you're running it through the system, and you really understand the type of plan that they have. Is it a high deductible plan? How much of the deductible have they met? So that it really puts you in an informative situation of being able to have the intelligent conversation with the patient and at the time of service and in advance. Setting up a patient portal for patients to view eligibility and claims data is really a best practice at this point. Using automated appointment reminders. A lot of this is integrated into your electronic health records, being able to, really allows you to prevent missed appointments. And also allows patients to review their balances and make payments and review the coverage before or shortly after service. You want to make sure that your credit card processing is optimal, that you accept all types of cards. Setting up automatic payments. This would include credit card on file processes. Are you doing that currently in your practice? Ideally, a modern practice should support payment by cash, check, credit card, phone payments, online patient portals, and patient payment plans. Make sure that you're incorporating the collection of past due balances in your process. So, if you're using your current documents internally, making sure that the information, not just for today's visit, they owe $25, that if there is something from the past visits, that's included as well for the people that are having the dialogue, that they have that information on past balance and at least can offer, if the patients need more time, offering that payment plan at that time of service and letting them know what those amounts are. Take advantage of online resources. The AMA has great point of care pricing toolkits, and there's a ton of other different tools that are available as well. Using your data analytics to implement process improvement. So going in and really looking like historically on, well, where have you not collected? So it's really kind of taking that step back and saying, okay, well, I have $300,000 in patient balances that were not collected at the time of service, and really looking at, well, how can we use that information and give education back to our staff, refine our processes, but using the current trends, and we'll talk about this a little bit further with the dashboards as well, but using data analytics to implement process improvement. Also include financial procedures in a welcome pamphlet, gives you an opportunity to present clear expectations related to financial responsibility. And then lastly, provide scripting and invest in training. So we're going to just do a little bit, we're often asked for scripting and how to speak to patients and so forth. So scripting is really, we feel a must. I mean, it's really good. It promotes consistency and professionalism, and really showing our patients that we're empathetic and, that in asking for money, and that we're really, all saying the same thing. So if you have a number of different people in your practice that are working with patients, you're consistent. Create interactive tools for your teams to be able to have something that they can reference. So in terms of just some scripting itself, we're going to just get into a little bit of questions and examples here. So the first one would be to avoid open-ended questions that result in a negative response. So, for example, Mr. Smith, you have a $500 deductible. Can you pay that today? Well, if you ask like that, you know that probably 85 to 90% of the people will say, no, I can't pay that today. So how can you kind of shift that into a result that you're looking for? So using close-ended questions when asking for payment. So for example, Mr. Smith, according to your benefit plan, your patient responsibility includes a $500 deductible, which has not been met. Will that be cash or charge today? So you're shifting that and you're setting that conversation to what you're expecting. Will not work 100% of the time, but at least instead of asking, can you pay for that yes, no, you're asking, how are you planning to pay? As you know, many patients will just say, just send me a bill. So shifting that to your expectation, your policy. We collect copays, deductibles, and estimated payments at time of service. So, moving away from that conversation in terms of just sending a statement. I know we've all encountered this, my mother is responsible, or my father is responsible, or whomever is responsible. That's something that we encounter and is a tactic that's used when, they don't want to pay up front, but really shifting that to, I understand that you have an agreement with your mother, but I'll be happy to give you a receipt so you can get reimbursement from her. But our policy does require that we collect a deposit from you today. A lot of patients do want to pay over time, and they might have that larger high deductible, so they want to be, an opportunity to pay over time. So just saying yes, we can arrange for interest repayment plan, but we'll still require something from you today. So shifting that, yes, our expectation is to require a deposit, but we can set up a payment plan for you as well. And then, patients who just know they have the insurance card and just say that, that just can't be right. I have insurance that will pay. And just shifting that to, yes, you do have insurance. We verified it in advance, and we determined X number of dollars is your responsibility. And then how would you like to pay for that? Cash, credit card, et cetera. So just really shifting your conversations to, your expectation that payment is expected up front. I'm not currently working, just bill me, and just kind of shifting whatever your process is. We do have someone that can work with you to locate some financial assistance for your future visit. Let's get that discussion started today. So it's not just that it just goes to self-pay and that's it, that there is that process that it will allow to get them on insurance, or if there's an opportunity for Medicaid, et cetera. In terms of scripting, I think the bottom line is just preparing your team and the ones that are the face of the practice for objections, so that they're properly scripted, so that they really can answer anything. And I think as a team, just working collaboratively to be able to craft responses for all the different objections that can be posed, and working with your team to kind of refine that over time. Having a training plan and monitoring the quality of the work is important as well. Comprehensive and continuous training. Of course, we have a new hire process whenever we're bringing someone on board, but working with our teams and working with our staff, having web-based opportunity. Classroom may or not apply to all practices, but for larger practices, but having group discussions so that your teams and your staff are really tapping into one another and sharing what works and doesn't work. Also auditing patient balances to determine the disconnects in the upfront processes. So taking that step back and really identifying what's working and what's not and what can be improved. Is it a specific team member? Is it certain time of the day where maybe it's busier, that the processes aren't followed? So really kind of drilling down and conducting some audits to determine where the disconnects could be occurring. Okay, so in terms of revenue leakage with regards to eligibility, I mean, the bottom line is more than 25% of our payer denials occur because the patients are not eligible for benefits. So really providing service to a patient without confirming their insurance eligibility is a risk to your practice. So want to make sure that that really taking advantage of integrated eligibility, and we'll be talking about that in a second. Payer requirements such as referrals and authorizations can be missed if the insurance eligibility is not confirmed prior to service, and manual verification by phone or online can be very time consuming. So in terms of from a best practice perspective, fully integrating your insurance eligibility into your financial clearance process, like we talked about before, making sure that all of that information is available to your staff that are speaking to the patients. Understand the information that's being sent back from the payer, and sometimes it can be just a big spool of information, and just really making sure that the team members that are working with the information are fully trained. Establish a process improvement team to concurrently review all of your eligibility denials, no auth, and no referral denials moving forward. Really expand your financial clearance process. Conduct real-time insurance verification and eligibility review, pre-service and at time of service, like we've already talked about. And like I said earlier, interpretation of the output is key, making sure that your staff that's working with the information understands how to interpret it. Also, like for example, on the clearance process, I just want to mention, patients who are coming in with Medicare and have no secondary, do you have processes in place to screen those patients to determine are they eligible for Medicaid? Can we start, can we forward them to Medicaid, or do start an application at your end to make sure that they're getting that coverage that is available to them? Okay, moving into coding, charge capture. So believe it or not, we're 3 years post-implementation on ICD-10. We have moved from under ICD-9, 15,000 diagnosis codes now to 68,000 diagnosis codes. As we know, CPT codes are used to document procedures as well. In terms of from a leakage perspective, modifiers are also used to describe in more detail the services that you're providing. So sometimes they unbundle certain services or explain why multiple tests are performed. Proper use of modifiers is essential, and improper use can lead to false claims. So really want to be careful in terms of from a coding perspective. Your clinical documentation is paramount. You want to make sure that your diagnosis and procedure and your modifier codes are representing your documentation that's in the clinical record, so that everything is accounted for. There can be issues where things are overbilled or underbilled, so coding and charge capture is essential. From a best practice perspective, you want to make sure that you are using certified coders is really a best practice. Specialty software is also used in practices to really make sure that the coding is correct. From a chart to bill perspective, and Mark's going to get into this a little bit later, but you really want to make sure that you are capturing all of your revenue and that you're billing exactly according to the record and that you're not overbilling. So being able to use chart to bill reviews, sampling specific, doing 10 plus per physician to make sure that there are no issues with regards to documentation. And now we're going to move to polling question number 2.
Okay, on to our next polling question. Per MGMA statistics, 20% of physician practice claims are denied. What percentage of the denials are never worth? 10%, 25%, 50%, or 65%? All right, we'll give you guys about 10 more seconds. I'm going to close it out. And here are the results.
Okay, so not as good on this question. So 20% of the physician practice claims are denied, and 65% are never worked. So 10% of the group did get that one. So we're going to move now into follow-up and denials in terms of from a revenue leakage area of opportunity. So too often practices waste time working everything. So billing claims and following up too quickly, believe it or not, and not working on just the exceptions. So you're kind of statusing and saying claims in process, but due to the volume, unfortunately, some claims are missed. As we know, manual follow-up, it takes a tremendous amount of time, and you know, too many practices are not appealing the denials that they are getting. So, you know, denials are one of the largest sources of revenue leakage. So from a best practice perspective, you know, from implement the denial management solutions, use automated tools available to you within your system to notify your staff when claims are in danger of non-payment or denial. Understanding the reasons for these denials, CMS tells us that outside of eligibility, the second most common denial is timely filing. And that's concerning because we have a year to get those claims in. So really understanding the denial reasons and drilling down to those reasons so that you can really put in the process improvement. But if 65% of the denials are not being worked, really looking for areas of opportunity. You know, do you use an external resource to assist with denials? Do you have just used dedicated resources? Making sure that you are not in that statistic of the 65% of the denials not being worked. Also, assign a dedicated resource to monitor changing requirements with the payers. Often, as we know, managed care payers are famous for making changes, and a lot of that has to do with pre-authorization requirements. So keeping up to date and making sure that someone in your practice is responsible for keeping up to date with these changes so that you don't find out after the fact, oh my goodness, you know, Aetna made a change and we need to, you know, kind of backpedaling and there's opportunity, you know, unfortunately there's lost revenue. And then utilizing your bolt-on software, integrating denial letters within the process so that you're appealing as much as possible with your staff or using, like I said, external resources to assist. We're just going to move a little quickly here. Some of this we've covered already. So we're going to move over into the key performance indicators and dashboards. One of my favorite topics. You know, KPIs are the foundation to process improvement. Too many providers work so hard, but they're not monitoring key trends that will highlight the areas of opportunity to improve. KPIs allow you to identify a baseline. You essentially know where you've been, and you can begin to monitor your progress or lack of progress moving forward. Therefore, trending of information is so much more valuable than just a fact of at one point of time, really being able to tell that story. So for example, if you really want to decide you want to drill down further on improving point of service collections, you may develop some KPIs on trending the balances you haven't collected, kind of similar to what we discussed earlier. As you begin to understand more about these missed opportunities of identifying and collecting upfront based on real data, you can use those trends to change your staff's process in the future. Plus, as you drill down and continue to monitor, you'll find the staff to be so much more engaged in improving, and you'll find that you have their buy-in in the future as you continue with your process improvement. I mean, bottom line is most people like to be part of the process, and as they have more information and data, you typically get a positive result. So KPIs should develop attainable goals, strengthen communication and trust. It's important to share that we're not finger pointing, but trending information to be better as a practice. KPIs also help to gain proactive feedback, and they really help to forecast future performance. And then sometimes I've seen, you know, some incentive programs implemented as part of KPIs and process improvement as well. So as things start to change, you know, maybe a gift card or something like that really is motivating as well. The organizing of your data and measuring of key trends and putting them into fancy charts are referred to as dashboards. Dashboards are actionable intelligence for physicians and practice managers. You know, our advice is when developing them to keep it simple. Dashboards should be concise snapshots. You may find, going back to some of the areas we discussed earlier, like revenue leakage opportunities, are good areas to begin to trend. So some suggested areas of focus, you know, financial and productivity information, more statistical data. For example, this would be volume information, patients seen, patients not seen, patients who cancel, et cetera, revenue, of course, generated. Revenue cycle data, very specific trends such as AR aging. You know, all the payers have different timely filing requirements, and they vary, so begin to really hone in on those accounts that are approaching untimely and using that in your dashboards and tracking the aging buckets by payers. As we know, some payers have 60-day and 90-day timely filing, and other payers have a year. So being able to incorporate that into your dashboard with like red, you know, yellow and red alerts so that you can really see where that exposure is coming. That's where the dashboards really can come in handy. Denial trends, of course, by payer, monitoring the denials by reason month to month. And that is pretty much it. We're going to close out the this part of it, and we're going to move into the risk assessment. Mark is going to take over from here.
Okay. Thank you, Kathy. Kathy has discussed the revenue cycle, best practices to minimize leakage, and the value of the KPIs and dashboard. And I'm going to get into the risk assessment and compliance-related issues. I'm going to cover the identification of risks, where do they hide, and what we can do about them as far as the process to mitigate the risks. Also discuss the top compliance risks of 2018, a compliance plan's best practices, the importance of having a compliance plan, what could go wrong scenarios for the revenue cycle and regulatory compliance, evaluation of information that you should look at in doing your risk assessment, and examples of physician regulatory risk and best practices in that area. Okay, identification of risk. Where do the risks hide? Well, there's key to any risk assessment process is to be able to identify them. And this process in physician practice should include input from physicians, the practice administrator, a compliance representative, and as well as other staff being involved. These risks are various categories, types. First area is regulatory, which is a broad area. It covers a lot of regulations. The OIG work plan, it's still in existence. It's not the way it used to be. It used to be an annual plan. Now it's updated during the course of the year, but there are physician areas on it. External audits and other billing and reimbursement compliance requirements. So this is a broad area. There's a lot of regulatory things at risk. What are they? You have to discuss it with your organization and your practice and how it affects you. There's also financial risks as far as your cash flow practices and financial reporting, things like that. There's something to consider is the culture, the staff morale and retention of your practice. You know, that's something that's never really, it's not focused on a lot, but is important. Operational risks, the delivery of the core operations of patient care, you know, what's your satisfaction, you know, are your patients satisfied with the care? Reputational risk, as far as if your brand, if your practice doesn't have a good reputation, you have a decrease in patient satisfaction. Also strategic risks, as far as what's the practice, the competitors out in the area, what's going on out there, you have to be on top of that. That's a risk and you have to be evaluated. And also very important is technology area as far as information systems and security. Once you've looked at these risks, once you identify these risks, then you have to, next step would be to rate them and evaluate them as far as impact on your practice. These certain criteria include the likelihood of occurrence. If it is going to occur, it's going to happen in the next year, maybe it's 5 years out. Are there any actions that you're currently doing that could minimize the risk, like an audit or something like that? After you've done that part of the process, you then prioritize and come up with your risk assessment and then implement procedures against that. Areas of top compliance risks in 2018, this is from a Health Ethnicities Compliance and Auditing Benchmark report. The respondents was over 1,000 healthcare executives, compliance, coding, auditing staff. Of that, 36% were medical practices, which was the highest proportion, so it was relevant to this topic today. You'll notice that documentation, coding and billing, and HIPAA are the largest categories that they felt were compliance risk 2018. I will discuss them further as we go further on into the discussion this afternoon. We'll talk now about the compliance plan. This is transitioned from voluntary to mandatory with the Affordable Care Act. So it's an important thing. And my observations as far as going physician practice, a lot of practices have complied with this, but they've created a boilerplate compliance plan and really haven't done an evaluation to determine the effectiveness of their compliance plan. It's on the shelf. The compliance plan is not a static document and is really part of the culture of your practice and should be updated and reflect the current conditions. So I'm going to go through the 7 points on the slide and discuss the components of them. The first one is developing and distributing written standards of conduct as well as written practices and procedures. This is very important. A component of this is the code of conduct of your organization. And basically, it talks about the principle of compliance with all laws, regulations affecting medical practices services, and abiding by standards of integrity, honor, and concern for others. These standards are the foundation upon the day-to-day operation exists. Code of conduct also impacts everybody in your organization, physician, employees, and they all should fall under that. It's a living document and should be updated periodically. The code of conduct typically includes your mission and values, quality care, conflict of interest, protection of information, and non-retaliation policies. The best practices in this area for code of conduct would be to document, have a documentation, maybe discuss an employee orientation, update on an annual basis, ensure there's a mechanism to communicate this to employees via the website or the internet. So it's very important that the code of conduct is there and it's communicated to employees. The next area is designate a compliance officer or contact person. It's important that a person has adequate time to allocate to this role. I've seen many practice administrators are also the compliance officer, so it's important they allocate time to this area. There also should be a committee that the compliance officer reports to and monitors the program in a structured and ongoing way. And the compliance officer should report on key statistics such as hotline calls, training, things like that, of that nature. The third area is conducting appropriate training and education of staff. Some best practices would be to develop an overall your practice training plan. For example, each category, such as physicians, coders, they should have specialized training. Compliance training should be included in new employee orientation and assign acknowledgement. And also, you should maintain training statistics. So training is an important area. The fourth item is open lines of communication. It's important that the employee feel comfortable that they can communicate if they have an issues. And one mechanism is an anonymous confidential hotline. There should be a written confidentiality non-retaliation policy distributed to employees to encourage communication and reporting of incidents and potential fraud. Next area is enforcing discipline through well-publicized guidelines. That's number 7 there, but it's really the 5th one. You want to, best practices, maintain a disciplinary policy for those employees who fail to comply, and the new employee process should include on the application some kind of representation that a prospective new employee is not ineligible to participate in Medicare or Medicaid. They've not committed any fraud. The 6th area is internal monitoring and auditing, and best practices is to perform your annual risk assessment, what I previously discussed, and also to perform appropriate audits such as coding and things of that nature. And the last area is responding appropriately to detect fraud offenses and developing corrective action. And this basically is develop a corrective action plan for any and all violations. So you can see that the compliance plan is a very important document in today's physician practice. What could go wrong scenarios? Well, Kathy's mentioned some of them, and these are, some of these, again, a lot of these are revenue cycle areas. You can submit a claim to a government payer for services that was not medically necessary, services that was not performed, inadequate documentation. So there's various things that could go wrong in a practice, and we'll talk more about best practices in some of those areas. Not complying with HIPAA. You hire a person who is excluded from, it should be, has been sanctioned by the OIG and things of that nature. So these are things that could go wrong. What kind of information would you evaluate when you're doing your risk assessment, and specifically for compliance areas? Well, you look at Medicare, Medicaid, how much Medicare, Medicaid business your practice has, your denials, as Kathy talked about, is an important area. Results of any fiscal intermediary or other outside reviews or audits, any issues, utilization by CPT codes. There's various data that you look at to be reviewed in your compliance and your evaluation of a risk assessment.
All right, moving on to our 3rd polling question. Does your organization have a formal compliance plan? Yes or no? All right, I'll give you guys about 10 more seconds. I'm going to close it out, and here are the results.
Okay, well, I'm happy to see that over 90% have them, and the other 9% they consider looking into researching this and get one implemented as soon as possible. Okay. Moving on. So now I'm going to talk about some examples of physician regulatory risks. These are not all inclusive, but I thought these were important regulations that you should be concerned about. False Claims Act, physician self-referral, the FCA, the Stark Law, self-referral, anti-kickback statutes, and exclusion authority. So these are just some, we're going to talk more, and the various agencies that enforce these laws, the Department of Justice, HHS, and OIG, and Medicare and Medicaid. False Claims Act, the risks, basically, in January, June 2018, there's approximately 200 million in recoveries for 40 cases. 53% of these cases were related to providers or clinics. There were other hospitals and other categories, but I thought it was interesting that 53% related to physicians. Examples of violations include, which we've sort of mentioned, things that go wrong, higher level services are actually performed and documented, and services that were not medically necessary. There's both civil and criminal penalties on the False Claim Act that you should be concerned about. So this is something, obviously, is a major compliance-related area. Some best practices for the False Claim Act is monitor coding patterns, review billing procedures and claim submission process. As Kathy talked about before, perform a documentation coding billing review, chart the bill audit review for medical necessity, billing for services not provided, failure to use coding modifiers and upcoding, things of this nature. This could be done via internal review or an external review. Primary reasons, you want to make sure that you're billing accurately. Typical, you do a minimum size of counters for each provider. Small frequent audits are the best mechanism to perform this. Very important to communicate the results to the physician. You would implement remediation efforts where applicable, and then implement training programs. So this is something that your group should consider as far as related to False Claim Act best practices. Also, just in this area, per this Healthnicity Compliance and Auditing Benchmark report, as far as groups that medical practices that require formal documentation and coding audits of individual providers, you'll see that the majority of the 60% for the practice size 1 to 25, but after that, 25 to 50 and greater, are between 75 and almost 100% do this. So it's an important best practice. If you don't do this, you definitely consider doing this as soon as possible. The next regulation is the physician self-referral, the Stark Law risk. Well, this is related to referring patients to receive designated health services payable by Medicare from entities that there's a financial relation as a financial membership unless an exception applies. The relationships could be ownership, investment, or compensation arrangements. The designated health services include many different types of services, but these are a couple examples here: clinical lab, physical therapy, inpatient, outpatient hospital services. So it covers a lot of different services you should be concerned about. The Stark Law is a strictly liability statute that proof of a specific intent to violate law is not required. The violation has various penalties and criminal and civil penalties. I just thought of the interesting two notable enforcement actions. One was related to practices that own both different type of specialties, and it was a complementary relationship, and so you should be concerned when you're of referring patients to another practice or organization that you own. And the other one was where arrangement was set between a physician, a hospital, a group, and basically to determine the services were really not necessary and were duplicative. So just be concerned of your relationships in that area. The Stark Law also talks about where there's four components that your relationship should have with other organizations. It should be in writing, signed by the parties, commercially reasonable without regard to referrals, and fair market value. So those are important concepts to consider in doing this. Some best practices regarding the Stark Law would be ensure conflicts of interest questionnaires are completed, signed, and any conflicts disclosed and resolved. This would include physicians, practice administrators, everybody as far as those that has a position of you view as a responsibility or authority within the practice. Where things are noted, if a potential conflict should be vetted out and flushed out to the satisfaction of the organization. Also, annual fair market value compensation benchmarks should be looked at, and also leasing arrangements for a commercially reasonable lease rate should be looked at as best practice. Next area is the anti-kickback statute risk. This basically is involving a remuneration to induce reward patient referrals for the business involving services payable by Medicare and Medicaid. Example of this I found interesting. Practice routinely waiving Medicare and Medicaid patient co-payments could implicate this statute. There's violations, there's fines and potential imprisonment regarding this statute. Best practices for this one example would be physicians should register with a federal open payments program, which is mandated by the Affordable Care Act. This program is where outside drug makers, device manufacturers, and group purchasing organizations who give, I won't say gifts, speaking fees, travel, and other benefits to physicians is collected and stored in a database. So as the last bullet point indicates, the physician should check this database to see that it's accurate, because you can be concerned that information be put on there that was not related to your practice. The next area is exclusion from the federal healthcare programs, exclusion risk. Found it interesting that between January and June 2018, the violations of this were 104 of the 1,500 violations were related to physicians, and 66% were family practitioners, general practitioners, internists. This is where OIG is legally required to exclude from participation individuals, entities convicted of criminal offenses, fraud, felony, patient abuse, and neglect. So if your practice contracts with somebody of this, or hire somebody who has been found guilty of this, you are basically can be cut off from the Medicare and Medicaid program and be fined. Some best practices in this area would be that you screen for all potential new employees or vendors before they come on board to make sure they're not on the sanction list. Then for existing employees or vendors, you do it on a monthly basis, and any potential matches you vet to confirm and check their social security numbers to make sure they're not the person that's on the sanction list. And your employee application process should include some kind of representation that they've not been sanctioned by the Medicare Medicaid program. So this is important because people, you don't want to hire anybody that's on the sanction list. It could be detrimental to your practice. The next area I'd like to talk about is Office of Civil Rights, or HIPAA risks. HIPAA compliance is monitored by the Office of Civil Rights. HIPAA has two components regarding the access of protected health information and having controls over that, and also security, the security of the devices and things of the data that you have. This HIPAA will be for 2019, one of the major compliance issues in 2019. Breaches can occur related to protected health information from a combination both internal and external hackers, viruses, and things of that nature. I just found it interesting, in October of 18, there was one of the largest in history, $60 million, and infected nearly 79 million people. So this HIPAA is definitely a big issue. Some best practices basically would be to perform evaluations of the access to of protected health information for your and policies, procedures, identify any weaknesses, and develop a remediation plan, and do a similar process for security, as far as of PHI, and any remediation plan, and test all the deficiencies and make sure controls are put in place. With that in mind, I think we're up to polling question number 4.
All right, so moving on to our fourth and final polling question. Which is not a best practice regarding a physician practice compliance plan? Develop monitoring and audit techniques, conduct appropriate training and education of staff, evaluate operational criteria for expansion of your practice, or provide an anonymous confidential hotline for complaints. You guys got 10 more seconds. I'm going to close it out. And here are the results.
Well, this is pretty consistent to the other polling question about compliance plans. 85% of you got it right, and that's pretty consistent with the compliance plan. So yes, the answer is definitely a C, to evaluate the expansion of your practice. That's an important issue, but it's not part of your compliance plan. So thank you for your participation. Okay, I have just 2 more topics to go over. I'll discuss them briefly. As far as the first one is data breaches, cybersecurity risks. We We all know that's out there as far as the sensitivity of the information. Oh, okay. So with the proliferation of mobile devices and the number of security exposure points have increased, any incident in this area is financial exposure with fines and penalties, reputation harm, damage to those data was compromised, and then it could impact your critical system. So the risks are are out there. Data breach costs, there's hidden costs, there's litigation costs, cost of investigation, damage your reputation, public relation costs, increase insurance premiums, and increase the borrowing costs. Best practices, as far as the data breaches, you want to identify what assets need protection on what systems and data, what safeguards are available to protect you, the security training, access to network security, encryption and backup, what techniques can you detect incidents, monitoring tools, security monitoring services, how can you respond to this, what techniques can contain the impact of incidents, quarantine breach, response plan, forensic analysis, and recover, what techniques can restore your capabilities. So that's a quick summary of That's a quick summary of your of HIPAA of data breaches, cybersecurity. The last topic is credit balance risk. It's also under the Affordable Care Act. Medicare and Medicaid are the key credit balance issues where you have 60 days of identification to repay the overpayment, and retention overpayment is actually a False Claims Act violation. The examples of these credit balances where a physician is paid twice for the same service.
Excuse me for interrupting. Excuse me for interrupting. Can you just switch the screen back from the polling question? Thank you.
We did it. For some reason, we hid the responses, but for some reason the screen isn't showing.
Oh, I do apologize. Just two more screens. I'm almost finished. The credit balance is, and again, so the best practice for credit balance is to validate accuracy of your credit balance aging report, determine your staff are trained to take care of this, and determine the controls are in place to ensure that future Medicare, Medicaid credit balances don't exceed 60 days. That's the end of my part of the presentation. Hopefully the takeaway is about an effective compliance plan and the risk assessment process and how it could impact your practice. Apologize, it appears that the screen's frozen, but I guess we'll give it back to you.
Okay, thank you, Catherine and Mark. I'm now going to read the questions from the question box. If anyone has any additional questions, please type them now. And so the first question was, are the slides available to print? And that is a yes. We are going to email all of the slides to all of you attendees, and you will be able to print them. The second question was, can you clarify how you can use appointment reminders as a revenue management tool when it is automated?
So I think it's just a matter, the point that we were making was just making sure that you have the appointment reminders as part of your process. And a lot of the newer systems have that integrated in, but just that's really considered a best practice to have a reminder process.
Okay, the third question is, can we get a recording of the session? Yes, all of the sessions are recorded and they will be posted and emailed to you as well. The next question is, how would you best recommend to audit patient balances?
So I think in terms of from an auditing perspective, being able to slice and dice your patient balance receivable and work with your system vendor or someone who is seasoned with just doing some more advanced Excel techniques, and just be able to kind of, maybe you look at a particular period of time, maybe it's 1 month, and you look at your patient balances to determine what are the payers, and then kind of, begin to kind of slice and dice it and break it down. Is it, like I said before, if you can drill down into day of the week, time of day, as much advanced information and data elements that you have available to you in your systems, I would recommend slicing and dicing and drilling down and really looking for areas of opportunity in terms of being able to educate your staff. So like I said earlier, it's not a matter of reprimanding anyone, but really looking at the trends and being able to come up with the process improvement. So I would start with slicing and dicing the data through Excel or through your vendor.
And if I can just add, you should definitely, as part of that process, look at the credit balances within that aging.
Any other questions?
And so the last question we have is, do we get a certificate of attendance and how? So we just ask you to please send an email of a request to your state staff email, and we will give you the instructions on how to collect your CEU. Are there any other questions? Okay, if there are no further questions for the day, so the state staff you can find on our website. So we have a few states in here. So for example, it could be staff@mainemgma.com, staff@vermontmgma.com. It's really posted on your website. You'll be able to find it on the homepage. So once again, this presentation will be emailed to all participants and will be available on our website for members only. If you have any additional questions, you can please reach out to the presenters directly. And also a reminder, you will be receiving a survey at the end of this webinar. Thank you for everyone attending and have a great day.